Artificial intelligence is poised to transform many aspects of medicine. Although numerous experts in law and ethics have evaluated potential problems associated with the use of AI in medicine, there's been relatively little focus on the ways in which AI trained on clinician data could be used to manage clinicians' practice. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Glenn Cohen, a professor of law and deputy dean at Harvard Law School and faculty director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard University. Professor Cohen has co-authored a perspective article about AI and the risk of clinicians becoming quantified workers. Professor Cohen, could you start by explaining what you mean by the term quantified workers?
Yes, I think the best way to understand it is as a worker whose daily task is monitored and controlled by AI technologies. Somebody whose autonomy, the benefits of discretion based on their expertise are restricted. And we've seen this in other industries, warehousing, long haul trucking. Typically, I think we picture this mostly in more blue collar industries. And one of the points of our article is that this may be coming for medicine.
So what types of AI-based monitoring tools have already been implemented in clinical settings and what others might be in development?
Outside the clinic, we've seen this in terms of keystroke logging, recording screenshots of computers at dictated intervals without consent, the use of trackers to sense a worker's location, for example. So a sensor attached to the body, and many of us now today actually wear a lot of devices that can track us in this way. But in terms of medicine, I think one of the first use cases you'll see is with patient records and documentation of patient visits. So we've seen a lot already of entrance of ambient scribing into medicine, where we have recording of visits with patients, summarization, and also possibly analysis of the time spent with patients as a way that might be beneficial to an organization trying to change practice styles or trying from an economic perspective to maximize kind of revenue for a hospital system or a healthcare practice.
And then how could information from these AI monitoring tools be used by other parties, payers, malpractice insurers?
So when we think about this, and I want to be careful here because overall, I'm a relatively optimistic person about AI and about technology. And as a lawyer and as an ethicist, my job is often to highlight the dark side of it. So I want to be measured here, right? But there's a sense in which what is currently seen is input and output. A physician sees a patient or another clinician sees a patient and we get some kind of output on the back end. We've got some kind of recording of what's reported as the time spent, what was done during the visit, and then we see a result downstream and we try to causally put the pieces together. What this allows potentially hospital systems, payers, malpractice insurers to do is to really go deep within what's happening in that visit. So, for example, to have a sentiment analysis to try to understand how did the clinician approach the patient? How did the clinician kind of follow or not follow recommended guidelines? How did the clinician spend the time? And in a way that we could do this in a bespoke way, if we could listen into every single interaction between clinician and patient. But AI just allows us to do this at scale and in a way that's much less costly. And that's what we've seen in other industries. The ability to do this monitoring kind of at scale at a much lower cost increases the temptation to implement this.
In your perspective article, you outline strategies that clinicians might use to push back against this quantification. What do you see as the most promising tactics?
I think the most promising tactics are to really have a seat at the table. And the question is how you have a seat at the table. And in the paper, we suggest kind of elements of what might be a clinician bill of rights for AI usage. That's something that I think would be nice to achieve, but how do you get there is the question. We've seen in other industries attempts to kind of thwart monitoring. So my favorite example are what are called mouse jigglers, which are making it look like your mouse is working even if it's not. I think that's going to be much harder to do in medicine because many of the ways to thwart AI may also hurt patient care, increase malpractice liability. So instead, I think the best recourses are one is naming and shaming. That is to say, identify hospital systems or payers or malpractice insurers that are being invasive and trying to bring it into the public eye and to make a case as to why this is bad for the profession and ultimately bad for patients. thinking about organizing, so collective bargaining is a possibility, unionization in some spaces. And then I think more generally, it would be nice if internal pressure can be brought on some of these systems such that we're not asking them to be reactive to clinicians and others being upset at this practice, but instead introducing a best practice where there's a much more shared governance when these kinds of technologies are introduced.
Finally, getting back to the Clinician Bill of Rights for AI that you mentioned, who should be involved in creating that kind of document? What provisions could it include? And how likely do you think it is that this will happen?
In terms of who should be at the table, my view is all stakeholders who are affected by these decisions. So, in a hospital system, just to use that example, it's hospital leadership, it's the general counsel, it's clinicians of all stripes, but it's also potentially patients who have a right to understand how this is being introduced. In terms of what should be included, we suggest, and again, our view is this should be a governance process, this should be a process of deliberation. So, we kind of giving some ideas. We don't mean to be the final word about this, but a right of information that we should have all clinicians informed when AI is used in a patient's care, right of participation. So healthcare systems should commit to governance processes that involve clinicians in decisions about implementing AI tools when it's going to affect a clinician's autonomy or livelihood. A right of privacy, that is, that healthcare systems should it state clearly to clinicians when and with whom AI analysis of clinician care delivery will be shared and justify why that's being shared. And finally, a right of quality assurance. Any AI tool that's going to pose more than a minimal risk to patients, healthcare systems should commit to pre-implementation review, regular post-implementation assessments, and the results of those analyses should be shared with the stakeholders, most importantly, clinicians. In terms of how realistic I think this is, I think that's a very good question. We definitely have healthcare systems that I think are leaders in the space that are implementing AI very quickly. And they're being very thoughtful about how some of them are being very thoughtful, I should say, about how they regulate and how they review. It's not a cheap process. And all we're saying is that once you're doing all of this work on that side of it, we should also be involved in clinicians very directly because it's their ox that's going to be gored, not just patients whose lives are going to go better or worse from AI implementation.
Thank you, Professor Cohen.